Here we go. Rebuttal. So in 2 minutes, I'd like to leave you with a couple of thoughts. First off, epicardial inflammation, such as causes myopericarditis, is not a good target for an endomyocardial biopsy. Enough said. Number two, the histologic diagnosis of myocarditis is not universally agreed upon. There's most people would say that the older Dallas criteria on the upper left are not the correct way to go, but amongst the immunostains, if you look at the literature carefully, there's a lack of consensus on what should be the proper diagnosis, histologically. Number three, there are different bioptomes, and I don't know where you work or the kind of bioptomes you use, but smaller in this size is better, probably, at least in outcomes data. I'm not going to show you the raw data. We can talk about it afterward. You can have my email. And finally, I would advocate for electrogram guidance. We use this in suspected sarcoid to minimize sampling error. In this paper, we had a sensitivity of 70% in a cohort. Historically, we would have expected 20 to 30%. This is hopefully going to be funded in a funded trial. We'll be validating this in a much larger cohort. Again, I'm happy to refer you to this paper, other papers we're publishing, and support that. The bottom line is this, that biopsy can be useful and should be used, using the guideline language, in those patients in whom it's going to make a difference, and you have no other way of getting the correct diagnosis. Very important. All of us in our cardiology practices will see people like this. If you do not have biopsy available at your medical institution, please refer that patient who needs the procedure to a center where you can have it done. But however, a lot of these patients do perfectly fine with guideline-directed medical management, and I think that you don't need to do a biopsy in all patients with myocarditis based on the overall data. Thank you.